All right, we're at the top of the hour, 4 p.m. West African time, and I'd like to say good morning, good afternoon, good evening to you, wherever you are joining the webinar from this day. We'd like to welcome you all to the webinar that is organized by the Center for Translation and Implementation Research of the College of Medicine, University of Nigeria. And today we have a very special guest in our midst, and he happens to be one of us at the Center for Translation and Implementation Research, and I will introduce him in a bit. So let's just listen to a brief bio of our guest. So Dr. Ezanolue is an experienced clinician, scientist with more than 25 years experience. He's currently the vice president of the Healthy Sunrise Foundation and the director of the Center for Translation and Implementation Research at the University of Nigeria. He leads the Nigeria Implementation Science Alliance, NISA, and is the country lead for the Central and West Africa Implementation Science Alliance, CAWISA. He's board certified in pediatrics and infectious diseases, and his research focuses on the use of implementation science to enhance effectiveness and quality of health services to improve health outcomes. Presently, he is a PI on more than 25 peer-reviewed research projects that include the grants from the National Institutes of Health of the United States. So with this, I would like to welcome to speak to us today on building blocks of implementation science grant proposals, Professor Echezona Ezanolue. Sir, you're welcome.
Thank you, Dr. Onyeka. Thank you so much. I am going to try and advance my slides. Let me know if you can hear me very well.
Loud and clear, sir.
Okay. So while we're doing this, I will not have the opportunity of seeing questions on the chart, but what I want you to do is that if there are questions that people prefer to put it in a Q&A, that way it stands out from the chat. The chat, of course, is a place for you to say hi, welcome, because also it's a good time for you to network when you meet people you haven't met for some time. What I do want you to do is to use the Q&A questions. The Q&A button will allow you to put questions there. And because we want this to be interactive, Dr. Onyeka, feel free to stop me when there is a question on the Q&A that you want me to take charge of. I am not going to spend a lot of time. Most of you that have heard me speak before will know that I don't do slides, but I am going to try to use this slide to guide you on what we are going to do. Jude, how do I advance the slide? Okay, all right. So I am going to try to advance them, but what this slide is really going to do for us is just to have you focus on the things that we're going to cover today. But I wanted to be able to make some clear distinction and definition of two things that sometimes people confuse. And that is implementation practice. Implementation practice is something that we do so well in Africa, because most of the projects that are being done there are all implemented by Africans. Why is that important to note? Because even when projects are being implemented by the lead organization, World Health Organization, whether it is by the National Institute of Health, whether it's by PEPFAR, whether it's by Harvard, Hopkins, Duke, whatever university that implementing it, at the end of the day, at the implementation level, it's going to be a lot of Africans. And a lot of them have this expertise in implementation practice. And implementation practice, and these definitions here from NIH, is using interventions in healthcare and public health settings. That is the act of implementing something. So if we wanted to increase HIV testing and we go out there and we increase HIV testing of pregnant women, that's implementation practice. We go out there, we want to increase HPV vaccination of adolescents, that's implementation practice. We go out there, we want newborn screening for sickle cell. That's implementation practice. So then how does it differ from implementation science? So whereas the implementation practice is implementing something, is the act of that implementation. One of the major outcomes for implementation practice is to increase the number of pregnant women who are screened for HIV, increase the number of newborns who have been screened for sickle cell, increase the number of adolescents who have gotten HPV vaccine. All these are implementation practice with implementation outcome. When you now turn over to implementation science, you see the difference there with studying the use. So at this time, you're not just implementing, you are looking at how the use of interventions in healthcare and public health setting. And there are these two sub-definitions that NIH put there that I like a lot, is that the scientific study of methods to promote the systematic uptake of research finding and other evidence-based practice into routine practice. Implementation science is a study of the use of strategies to adopt and integrate evidence-based intervention into clinical and community setting. So let me give another example how those things. So if I is going a program that is an implementation practice, and my goal is to increase the number of women who test for HIV. And that's the thing. I go in there, I do whatever I need to do to get women to test HIV. The end result is that I increased the number of people who tested for HIV. If I come in there to work with an implementation practitioner, and this is something people don't understand, that in all implementation science, there is an implementation practitioner to do it very well, because implementation science is in real life. So if I come in as an implementation scientist and want to combine and collaborate with an implementation practitioner to work, then what I'm going to be able to say, okay, why you are trying to get these women to screen them, I'm looking at the methods you are using. Are you testing in the health facility? Are you testing in the community? Is the community you are using churches? Is it the marketplaces? Is it a mobile testing van? It is a self-testing that you give them the test for themselves. So these different methods that you use is what I'm looking at. So that's the difference in terms of that implementation practice and implementation science. So in that implementation science, yes, I'm looking at what the outcome is, how many people who screen for HIV, but more importantly, I'm looking at the method. Why is that method important? So that's what we're going to talk a little bit about these building blocks of implementation science, and be able to see how do you think about it, and how do you see along the way the things that you can put in, even with your implementation practice. This is something that you do, because I want you to think about the implementation science as part of, or implementation research as part of what you do, so that you can see the problems. For example, you're trying to get these women into getting HIV testing, and you realize that there is a problem here. So one of the first things that you want to do from your practice is to be able to identify a challenging but modifiable problem. And when I say this, sometimes people say, what do I mean by a challenging and modifiable problem? And I'll give you an example. When you have a problem, when poverty is the big challenge, just know that you have a very huge problem, but you may not have a modifiable problem, because poverty will always be there. So friends come to the US and they see people who are still homeless. And they said, can you believe it that in the richest country in the world, there are people sleeping under the bridge? I said, because there will always be the poor among us. And that may be due to mental health, that may be due to other reasons, but the fact is that there are problems that you can't solve. That does not mean you can't change them, that you can modify them. But it depends on what your target is. So if you say, I am going to, the major problem that we identify that is obstructing this is poverty, you're not going to be able to cure poverty. You can decide and say, if people are poor, what does it stop them from doing? Maybe that really the problem there is transportation. And the challenge that you actually have is that they lack transportation and they don't have the money to do that transportation. So be specific about it and said, we are going to tackle transportation to the health facility for the pregnant women because that is the major thing. Or instead of transportation for them, because it might not be sustainable to keep giving them money there, why don't we bring the testing to them? If all of you will remember, for example, in HIV, when it started, it was all facility-based, but then it became community. I remember one of the projects we did was in churches, and we had more than the number of people that we needed because everybody could go to church. Churches have known how to bring that, and mosque and all the religious institutions, how to get it to the people. So most people will tell you they don't have to enter a taxi or a bus to go to church or mosque. Usually there is one close to them they can walk to. And we decided to use those things as vehicles for health interventions. So being able to identify a challenging but modifiable problem is one of the first things you want to do as someone who, whether you're a clinician, seeing patients, whether you're in public health, implementing programs, you want to be able, and you want to begin to do implementation research and want to use the principles of implementation science, then you want to be able to clearly identify those challenging but modifiable problems. Then the second thing that you want to be able to do is to be able to say, what is the knowledge gap? What don't we know about this problem that I think exists? So you may be in your little corner and you think this is a huge problem. Wow, why haven't anybody thought about it? Then you go and look and find out that there have been tons and tons of paper published in those areas. One of the things I always say is that remember that as an implementation scientist, remember that as an implementation practitioner who wants to use implementation science, that you need a team. And people in the team have different skills, and we'll talk about it. And that is important for you to not to have the same people with the same skill in your team because they don't bring anything new that you don't already have. So the where to start, first of all, is to know what is it that you know and the skill set that you know. You know how to implement this project, but you may not know what the knowledge gap is because you have never done a systematic review of the literature to find out what is out there and what is known about this problem that you have identified. And that may be that you have a master's student doing a PhD that is working with you, a postdoc or a PhD candidate that is working with you, or a faculty member in one of the universities close to you. This is one of the reasons I think programs and universities and research centers and research institutes should combine their strategies, combine their strength to form a good team because they can do that systematic review. So that doesn't mean that you are not part of that team, but that's the skill they bring to the table. They're not going to be the one who will go into the community to do the HIV testing, but you can do that. But in that together, they can bring out that gap and be able to clearly show you what the gap is. And when you have that gap clearly identified, then you now say, what is an interesting research question here if I want to do research? Well, you have to remember, think about it, that most research are funded by public money, whether it is NIH funding, WHO funding, all of those come from taxpayers, you and me. As we pay taxes, that is what funds the NIH. So NIH spends that money, and that's once in a while you see the NIH being called to the Congress in the United States to say what they're doing with the money trusted to them. You are doing global health. What is it that you're doing? So one of the things that you want to know, you want to be thinking about as you try to identify an interesting research question is the question, so what? So you say, in this thing I'm interested to study, what is so what? Why would my neighbor care? I mean, the easiest way to is to pick one of your friends who is not in your field, who is not interested in what you do, and say, this is what I'm doing, and just gauge their interest. You know, and then some of them you see they're rolling their eyes already and say whatever. Or as you try and explain what you do, you actually see them interested in it because it simply affects their way of life. It really matters to them. And sometimes I say the story about asking my mentor, how do I know what is an interesting research question? And he told me to go and read the newspaper. I'm like, what does the newspaper got to do with, they're going to talk about politics and going to talk about all the things going on. What do I care as a scientist? Well, you do care because the money that funds your research is to impact public. So what is the public talking about? Okay, if you're talking about, for example, in Nigeria right now, using that as an example, there is a lot of loss of human resources for health. For years, Nigeria built a very good background of people who are in medical school, public health, nurses, all of those people. Suddenly, there is a new thing in town that everybody's leaving town. And suddenly, one of the Congress people proposed that we keep them by force for 5 years, so that after medical school, they cannot leave the country for 5 years. They're not in prisons. But that's his political, thing to do. But people were talking about it, that doctors are leaving. Every day, 100 doctors leave Nigeria. And people are thinking, how can we? And the politician will get up and we need to reverse brain drain. Okay, we've been trying to do that. But you can't do that by stopping people not living for 5 years. But other people are beginning to think, how can we tap into those people who live so that they can still contribute? So you begin to identify an interesting research question, so that if you go to see a meeting and everybody is talking about the problem, because that's what is good, everybody can list the problem. It's so much easier to list the problems. So when they're talking about, people are leaving, we need to revise this, we need to stop brain drain, we need to stop medical tourism, we need to stop all the problems we have in Africa. But then you're thinking about how to do this. What would be an interesting question that if you come out and say, I think we may not be able to stop all the people leaving. They're leaving for a reason that we may not be able to do. Well, they're leaving for a reason of some, economic reasons for them to leave, some other security reason, for whatever the reasons. But the reason they're leaving is that problem has not been solved. So while we're trying to solve that problem and people are leaving, is there a way to make those people who leave be a little bit of brain gain for Africa? And suddenly you're able to come up with an interesting research question on health system strengthening. Because when I see people say, oh, my research is in health system strengthening, I say, what are you? Say, oh, only if the government can fund more. The government can fund more. They haven't been funding more. So what else are you thinking about? What's new? What is interesting? What interesting question are you going to look at as how we can do it? And some people have said, well, if doctors are living with 12 more nurses. And some people are saying, well, if doctors and nurses are living with 12 more of choose, but there are solutions. But getting those interesting things to say, can we leverage this and can we train more choose so that more choose, if we have more choose and then we have 5 choose, we have 3 nurses, we have done 1 doctor and they form a team. Can they actually serve a general hospital? When we don't have, instead of looking for 5 doctors, and can we provide those teams and be able to have work that each person do that ultimately benefit the patient? So being able to identify an interesting research question is one of the next step of the building block for implementation science. Then as you do that, that comes down to the next thing, which is demonstrating public health important. So here is when I'm thinking about things that are significant, which is part of what we just discussed a little bit, but you're also talking about feasibility, the impact, and then sustainability. What I say is this, is that if I have all of people that are here on the call and said, for being on this conference today, you are going to get iPhone, the 15. All of you are going to be happy and clap for me and raise up and very, very happy. And then I buy the iPhone, I send all of you, and I spend $1,500 to buy each iPhone. All of you will use iPhone, which is, you got an iPhone. Very nice, you use it. But there are things you can try to do. What if I actually take the $1,500 and give each of you for a phone? How many people will buy an iPhone? Some people will say, what do I need an iPhone for? I can buy this other phone. All I use my phone for is to call. I don't even go to the internet to do anything. And somebody said, I don't need an analog. Somebody said, well, I do go to Facebook, but I don't need an iPhone with all the things, because some of the phones we have, for example, we use like less than 10% of them. But again, why is that important? Because if you throw a big money on a problem, you may make that problem seem to change. But then it's not sustainable. So I'll give you another example. somebody was trying to increase HPV vaccine, and this was a story a friend of mine told me from Kenya. And when they designed the place, they went in and bought trucks that will go in and immunize everybody and get the things out, just like Nigeria would do with polio. Then, when they find out is that 6 months into the program, all the vehicles were stuck on the road because the roads were not tarred. The roads were, once the rainy season came, they couldn't ply the roads. The cars were all packed. And somebody said, we could have bought bikes for these people, because these people always, even during the rainy season, they come to the market. How do they come? They use bikes. So somebody said, okay, let's buy bikes. And they buy bikes, and their program got back up. And for each of the car they bought, they could have bought 10, 20, bikes. But nobody thought about it. They threw the money at it. And then, of course, you go as far as you go to make some changes, and then the rainy season come, and then the buses couldn't go any of those villages. So again, being able to think about those questions and the interventions you are proposing, to think about the significance of the problem, the feasibility of the intervention, the impact of the outcome, and the sustainability of the process that you're using. So that brings us to talking about the evidence base to be implemented. So one of the things about implementation science is that implementation science is not the type of research that you're trying to discover the drug for HIV, the drug for sickle cell. Those are different kind of drug, clinical trials and all the other things that you're doing. What sets implementation science apart is that most of the things that needs to be implemented in implementation research or implementation work has to be evidence-based. So this is not a time for you to try to check whether Tylenol works better, or Fansidar works better than another anti-malaria. If you're doing those are clinical trials. That's some of the things that are done. So I will give you an example. HPV vaccines, when we did that study in the US, it was 3 doses. Then we got to 2 doses. Then there was a large study in Africa to say, with 1 dose, do this. So that's a clinical trial where they give people 2 doses and give them 1 dose, and then try to say, does it 1 dose actually protect? And the result shows that, wow, 1 dose does make a lot of difference. Then the implementation scientist comes in and say, how do we get the 1 dose to people that is there? Nigeria is, and I use Nigeria, that's where I live, that's where I come from. So if you think about it, Nigeria is trying to introduce HPV vaccine at the national level. Okay, so the question some people will ask, okay, are we going to do the 2 doses that is, or are we going to do the 1 dose that is evidence-based? Are we going to try to get everybody the first dose, or are we going to try to spend the time and the money to try to get everybody the 2 doses? Those are some of the work that implementation science and implementation research can do for you, to be able to say both things are evidence-based. We know that 2 doses work. We also know that 1 dose work, and we may put it in context, which is a very powerful word in implementation science, which is context. Just because the 3 doses, the 2 doses work in the US, and maybe he achieved 90%, and then you have the 1 dose in Africa and he achieves 85%, you may look at the context and decide that I will take the 85% because of the logistics of implementing a 2 dose. I will give you an example. In the short time I was executive director for primary care in Nigeria, I actually went out with people who were doing polio vaccination. And I wanted to see why we were having so much problem. And this was in Abuja suburb. And I just wanted to see, my interest at the time was in vaccine refusal and why people refuse. Because I felt like this vaccine is available, this vaccine is free, it doesn't cost you anything. Why are people not taking it? So that was my implementation science heart. So I went with them and we were going, I just told them that as they were going from house to house, if a woman or a family did not want to accept it, that I want to speak to the family. So we got to one of the family and they refused. So I told them that I wanted to speak to them. They said, no, they don't want to speak. I said, can you go in and tell them the executive director wanted to speak to them? Which was one of the funny things I found out, that he does have an influence. So the guy didn't believe that the executive director was there walking around the town with them. So he came out and he said, you're the executive director for primary care. I said, yes. He said, oh, you're the one that came from the US. He said, no wonder you're walking around this place because I've never seen one before. I said, I wanted to find out why you refused a vaccine that the government purchased, paid for, and then brought it to you. Why did you refuse it? He said, this is the 5th time they're giving my children the same vaccine. Why? Because there was no record of who have received this and who have not received it. And every time we organized an immunization campaign, the people that we got go the same place that they could go. They wouldn't go to the places that hard to reach, because it's hard to reach. They will go to the same place. So this woman have received 5 doses of the same polio vaccine, and she was refusing it. But it teaches you again how are the things about having the evidence-based intervention, understanding the context where you're working, and understanding the barriers, the facilitators to uptake of those evidence-based intervention, which is where your things are. One of the major things for you to know what is going to be implemented is to be able to look at the literature, see what is evidence, and sometimes, and more importantly, if you have preliminary studies gives you the context. And these examples I've given you is to tell you a little bit of the context that I find myself. I'm sure we have people from many different countries here. You can give me examples, just like I've given you about Nigeria, in the different countries where you come from. Then we're going to the next thing, the 16th, which is to demonstrate the capacity of the team to successfully carry out a study. You need to build a team. One of the things I tell my team is to say, don't give up your best skill because you're chasing something else. If you have 10 years of experience implementing program as an implementing partner, as a implementation practitioner, yes, you might decide to do implementation research and then say, I'm going to go study. But also, you can become part of an implementation research team. But what you bring to the table is a 10 years experience of being implementation practice. You understand the context, you understand the environment, you understand the culture, you understand everything that the science person that has a PhD from Harvard and has been in Harvard for 30 years may not understand. But together, both of you can form a strong team. What I have seen sometimes is that people say, oh, I've been doing this. Oh, I need to begin to become an implementation scientist. There's nothing wrong with that. But also remember that you already have something you bring to the table. And that a team, because if you become, let me put it this way, if I come in and you're an implementation practitioner and I'm an implementation scientist, me and you can work together. We can work together to put a proposal together, to put a project together, to be able to implement it, to look at the result. We are a very good team. And then tomorrow you say, well, I'm not an implementation scientist. Well, you're just like me. I don't need you because I already have me. So I'm going to go find another implementation practitioner because that's what I need to form a team. 2 implementation science people do not form a team. So being able to build that team is important. How you build a winning team in the things you do. People have expertise. The first time I did study, I went to South Africa to present it. The person that presented the work that I did as the scientist was the bishop of the Catholic Church, who was in charge, who understood the environment, who was very supportive of our program of putting HIV testing in the community, especially in the churches. So there comes the bishop. He said, how am I going to present? I don't know the science. I said, don't worry about the science. If there's a question on the science, ask me. But if there's a question about the context, the understanding, you better than me can present what we did here. And when he got there, it was so well received. I remember United Nations paying for his trip to come and present at that point. Why? Because he brought in an expertise, a lot of the people at the conference who have never seen a bishop present scientific material. So again, building a good team, demonstrating the expertise of those teams, which you can demonstrate with the bioscale, their profile, but more importantly, the preliminary work they have done. What I have seen a lot of implementation practitioners is that they don't know how to capture the work they have done over the years. I worked with one of them who, by the way, went from being an implementation practitioner for 10 years to getting a PhD and being an implementation scientist. But even with the PhD and being an implementation scientist, one of the biggest things he brings on the table is 10 years of experience on the field. He understands it. And that's very important. And he can give you preliminary work of project and project and projects that he has led. then it's nothing is clear to fit conceptual model. When you want to communicate those things to people, again, you have to put in a conceptual model, an implementation framework. Again, this does not, you don't have to spend as an implementation practitioner all your time on this. That may be what the person that you brought from the University of Nigeria, from the University of Ibadan, or the University of Lagos, or Hopkins, or wherever they come from. That may be what they bring for you. They bring conceptual and implementation framework. I've done practice, I've been a clinician for 27 years. I've done implementation research so many years, but I always say that when I have Gregory Aarons, who have been my multiple peer on many grants, when I have him in the room, I try to define myself differently, because I say he's a card-carrying implementation scientist. He's one of the people that designed and developed the EPIS framework, implementation framework, which I use quite a lot. So when he's not in the room, I say, oh, I'm the implementation practitioner, scientist. But when he's in the room, I said, I can define myself well, differently. But I actually can become an implementation practitioner because I'm a clinician. I still see patients. I'm down on the patient-facing level. So he's not a physician, he has a PhD, and he understands those conceptual and implementation framework. I'm a physician, I do patient care and understand the problem that are, but together we form a strong team. So when we are both working on a project, he has a very specific role that he brings in. I have a specific role that I bring, but one of the things that I have over the years have found a very nice place for me to be is for me to be a bridge between those implementation scientists and the implementation practitioners and be able to actually build those teams. So one of the things we have done is to build a strong team that actually can get projects done. So that when we are doing it, those include the fit conceptual framework and all the things that are coming. Then we're able to identify the implementation strategies. And the one thing about implementation strategies, I always give this joke, and people may remember this very well. There is a river called River Niger in Nigeria. When you go to the history book, it's written that the person that discovered River Niger is Mungo Park. And we always make fun when we're in school because our parents told us that they were taking showers and baths and washing their clothes and everything in this river before Mungo Park was born. How come that Mungo Park came and then everybody now say he discovered River Niger? Mungo Park did 3 things. He named it because the people, they have different names for this river. It passes many countries to come into Nigeria, passes through Nigeria and went to the Atlantic. But they have different names depending on the town they pass. He finally traced it and said, this is the same river, and it will be River Niger. So he named it, he defined it, where is pathway, and he specified it, talked about the people that surround the river as it goes around. So because he was able to name it, because he was able to define it, because he was able to specify it, he is credited with discovering River Niger, that people had been taking showers hundreds of years before he was born. So whatever implementation strategy, when I ask people, they say, oh, we gathered people together and we asked them, I say, how did you identify the problem here? They say, oh, we gathered people together and then we asked them and they told us. I say, really? So you did a focus group? He said, no, we brought people together. I said, yes, you did a focus group. He said, I thought focus group was something else. I said, well, no, what he did? He brought 8 people together that were leaders of their community and you asked for the barriers and your data. He said, yeah, that's what we did. I said, then name it. So one of the things I've found a lot that most Africans don't do is that they don't name things, they don't define it, they don't specify it. But you need to do those things for them to be strategies. Right now, all of us uses what they call the ERIC implementation strategy, which is an expert collection. But ERIC strategy will tell you that all the experts that were in that room to come up with those lists, none of them were working in Africa or was in Africa. They might have experience doing those. So, but there's an understanding of context that I think as you name things, as you define things, as you specify them, that you can actually contribute to science on the overall general things that we're doing. So I'm going to try to come, because one of the plans we have was to try to get this to the half hour and then make it more of a Q&A. So we are going to turn over a little bit in a moment to Q&A questions. And that will be where really what we wanted to do. This is half the hour, spend on this and have the hour throwing back to you to ask those questions that you want to hear about. So the next building blocks that I talk about is a strong research environment. You have to build that research environment, the infrastructure. You have to have a track record of recruiting and retaining patients in clinical trials or in whatever type of research you're going to do. When you're doing applications, you want people who can write you strong letters of support, not to say, oh, you are this, but to say they have worked with you. This is what they did. And in this project, they're going to work with you. This is what they would do. These are very strong letters of support of talking about their track record working with you, and in this particular project, what they will bring to the table. You also want to have a strong outcome measurement plan. So in overall, what I want you to pay attention to when you try to think about your project, when you think about bringing them together, I want you to pay attention to the background of the evidence-based intervention you are going to implement. I want you to pay attention to bringing a team with experience with the setting and implementation process. There is no need for me to go in to work. We have a project on cervical cancer screening, but I'm a pediatrician. I do implementation science, but I'm not an oncologist. Neither am I an OBGYN. But there are those people in the team with the expertise who have done it, who are top of their game in that area. They bring something to the table, and each of us brings something to. And if everybody brings and carry their own weight, we are going to do very well. But it's always very good in thinking about the experience. When you suddenly have those people in time, and I'm trying to become an oncologist, and the oncologist is trying to be an implementation science, you finally find out that all of us, we're no longer on top of our game, because we're spending the time of being on top of our game to just become mediocre on another field. I don't want to be one. So I pay attention to my area and be expert in it. Then I bring it to the table. And I want people to be expert on their own and bring them to the table. So pay attention to the team that you're working. And then look at the research environment, the capacity to support implementation research. One of the things we've done in Nigeria is to build one of the first and largest practice-based research network across all the 6 regions of Nigeria, with 21 sites that are connected to 6 tertiary institutions for 27 facilities that we hope that will be an infrastructure for people to do research. That infrastructure is not built for one person. It was built for our national use to advance contribution of Nigeria to scientific literature. We always say that when people talk about Nigeria, or talk about Africa, they talk about East Africa, they talk about South Africa. And the reason they talk about them is that work gets done there. And they publish and they share the things. We always make fun that Malawi came up with option B that Nigeria implements. Malawi is smaller than one state in Nigeria, but they are the ones who brought the guideline that Nigeria is implementing. Why? Because Nigeria wasn't doing things, sharing it, publishing it, naming it, doing everything. Some people say, oh, we were doing that before Malawi came. I say, show me. Well, we didn't write it up. We didn't share it. Well, nobody says you are until you say, I am. So if you have work done, remember the last part of it, share it. And one way to share it, present it at meetings. And that's one of the things we're trying to do on the platform we have with the Nigerian Implementation Science Alliance and the Central West African Implementation Alliance, which we're trying to build strong from the bottom, but hopefully will become our African Implementation Science Alliance, where people can present the work they're doing in Africa for African policymakers to hear and listen to. I just wanted to end by thanking the National Institute of Health. They support the time. That's why we do these webinars for free, is because we don't receive funding for the webinars, but we receive support for the research we do. So we are very grateful to the National Cancer Institute, the Fogarty Institute, for the funding that they provide to our team. I also want to thank the Eleanor Proctor, Pyron Powell, because some of the slides that I have here also came from their presentation in 2012 about implementation science. That was when I was coming up with implementation science. And I remember one of the beautiful study that they asked me to read, and I will put it on the chat box, is implementation science for the non-professional. It was a very, very nice paper for me, because at that time I did not know what an implementation science was. I was basically a clinician who didn't know that what he was doing was implementation science, until somebody looked at my bioscape and said, "Wow, you've been doing implementation science." I said, "What is that?" So I also put up here our website for the Center for Translation and Implementation Center, and also our website for the Nigerian Implementation Science Alliance, and also an email should you want to continue to receive information about what we have in stock for you for the monthly webinars. You please make sure that you indicate that you want to be on the listserv, and you will receive information about the topics. And when you are able to, it will be nice for you to join us. So I will stop here and thank you for attending, and I will be happy to now take the questions. Thank you, Dr. Onyeka.
Thank you so much, Prof. So the first question says, who is an implementation scientist?
Yes. So again, it goes back to that definition that I want to go back again here, which is the person who is an implementation science is the person who is studying the use of intervention in healthcare and public health setting. Whereas the implementation practitioner is the person who is using interventions in healthcare and public health setting, implementing this project. So while the implementation practitioner is getting those results done, the implementation scientist is a little part of that. He's a little person in the whole big picture. What he does is to study the methods, the interventions, the implementation strategies that will help the practitioner do the work they do very well. So when you talk about it, people think the implementation scientist is the bigger person. I think the implementation practitioner is the bigger person, because you need a lot of implementation practitioners to get the work done. You need a few of implementation scientists to add, to help them figure out the best strategies, the methods, and other things to achieve the public health impact they want to achieve. I'm hoping that answers the question.
Yes, that should. So your next question is from Chukwe Ebuka, who says, he's thanking you for the talk. And he says, when there is a novel combination of distinct interventions of known efficacy, can this be considered implementation science?
So the implementation science, one of the things implementation science does is at the spectrum. There's a spectrum of research. Implementation science is usually put in at the fourth level, which is at the end when there is an evidence. If an intervention is not proven yet, you are going to test the efficacy of that intervention. It's not purely an implementation science, unless you go into what we call hybrid intervention, hybrid implementation interventions, where you're looking at things that are at the same time they're measuring the efficacy, they are also measuring the implementation outcomes and implementation strategies. So there are ways now to combine them, but distinctly, if something is not evidence-based, it's not really implementation research or implementation. That is, it has to have been proven to work. So you're not going to go to a pregnant woman to give them AZT. If you're doing that and you don't know whether AZT works in preventing HIV transmission, then you're still doing a clinical trial, which is, there at the beginning, there's a phase 1, phase 2, phase 3 clinical trials. But when you show that the AZT does work, then you want the pregnant woman to get the AZT that you know that works. Then you are now going to implementation research. So it depends on what you're looking at and what stage that intervention is. If it's proven to be evidence-based, you're not talking about implementation science. If it has not been proven, it's not really implementation science, except when you're using design that combines both. Thank you.
Okay, so more questions for you, Prof. Ogenekaro is saying, thank you for your very enlightening lecture. In your discussion, you mentioned poverty as not being a modifiable factor. Granted, there will always be the poor people among us, but scientific evidence also shows that at some local scale and from social determinants of health perspective, poverty can be modified. So can you elaborate on the idea of poverty as a modifiable or non-modifiable factor?
That was going to get me into trouble, but I wanted it to. The reason I say that is I've been a reviewer for NIH for a while before, and one of the things I always see people do is that in their problem list, they identify the biggest problem they identified is poverty. In their solution, there is nothing to solve the poverty. So because what we know is to cause poverty, there are certain things. So what I want is not to lump things on poverty. Instead, break down the poverty. For example, if people are poor because they are not educated, then you can bring education. If people cannot get to the clinic because they lack transportation, then address transportation. Because poverty, in my opinion, is a state of the mind. Who is poor? I took my kids born in America to Nigeria and took them to my village, and they saw the village people playing soccer with an orange. They didn't even have football. They didn't have, shoes. They didn't have jersey. My daughter plays volleyball. I pay $8,000 for that. And then they come down and they see these people enjoying the same game for no cost. So who is poor? So poverty in my mind sometimes can be something that is a mindset. That's why I think it's not an easily, maybe the word I should have used is not an easily modifiable factor. But we can find some of the things that make people poor. For example, we talk about it, education, knowledge. You talk about development. So if you say, oh, well, the people can't go to the hospital, because then you can say, okay, can we have a health post there? So you can attract it. So you talk about access, you talk about knowledge, if you identify the component of the poverty that you can address, I think it's better to now design intervention than to say poverty, because poverty, in my mind, is a mindset. So who you think is poor may not be poor. Just because they don't have a car doesn't mean they're poor. If you look at some of the measures we measure poor people, sometimes the people we think are rich are not rich. People that work make more money than people make in Nigeria and the US, but they still cannot afford the same thing. They cannot afford a house, they cannot afford a car, they're actually living on food stamps, and they're living in the US. Who is poor? So I think the poverty thing needs to be re-examined. And I know I'm becoming philosophical here, but I want you to break down the poverty to the modifiable components. That way you can better design intervention. Let me stop at that, and hopefully that I was able to answer some of that question, but it's a very interesting question.
I think you were. So the next question from Godfrey says, how is the cost effectiveness of sustaining implementation science interventions studied? So how can you study the cost effectiveness of IS interventions?
There was a time that we're talking about that no study should be done in Africa without an implementation, without a cost effectiveness component. And there are very, very good people that in Africa that now can do cost, because one of the things about cost effectiveness is that you have to understand context. There is a cost effectiveness of intervention. There's also the cost effectiveness of implementation. So an intervention, for example, may be buying the HIV medication. Think about it. The cost of reducing HIV, there's cost of getting the HIV medication. But just like we noticed with the COVID vaccine, even in the US, the COVID vaccine was available. It was in my office, and I was throwing them away because the people wouldn't take them until they expired. We had to change. Think about now we made the thing, we got the vaccines. It's all everywhere. It's all in our offices, but they're expiring because people can use it. The other places where it wasn't available at all. But in the US at the time, it was available. I remember very well going in to take, when the vaccine came, I was one of the first people, and then one of the nurses in my place told me that they want me to take it, and if every day I have to show them my head to see if I grow a horn, and if I'm going to still be alive by the next Valentine's Day, then they will take it. Luckily, I was still alive by the next Valentine's Day, and I didn't grow a horn, and they finally decided to take it. These are nurses. So there were other things that needed to be done in terms of those, and those become cost of implementation. So when you see a good cost analysis, cost effectiveness, all of those things done, you will see when it's done well in context that include the cost of the intervention as well as cost of implementation. But there are people who are very well to do it. I always go to people in my team. Professor Obinna Nwujekwe at the University of Nigeria is one of the most famous economists that we know in Nigeria and in most of Africa. key designs. When we want to do that, we say, can you, take charge of this section for us? Chimonoka is another health economics. Again, these are not the only people. These are the people in my team. So you can understand why I'm calling out their names. But I'm sure there are people who are there. But you don't have to be a health economist to do health economic outcome or cost-effective analysis. You need to have that person in your team to be able to take charge of that. Just like you don't need a statistician to become a statistician to analyze, to do a study, you need to have a statistician who can do that. So that's how I say that. But I do think that every implementation project that is going on, if not in the first time, but before it's ended and done finally, that there is a cost analysis that is done, whether it's cost effectiveness, cost of implementation, cost of intervention, that those components are shared because those are what drive sustainability. Thank you. That was an interesting question.
Yes. Two similar questions. One says, what's the main purpose and importance of implementation science in oncology and general practice? And another says, is it possible to do implementation science outside the public health field?
Yes, implementation science is done in everywhere. It actually wasn't done in health. A lot of what we do in health, people will remember, come from engineering. A lot of, if you look at query, if you look at all the quality improvement, which is what implementation science came from, is quality improvement. All of them came from engineering. So whether it's agriculture that you're going to, and you're going to say, there is no food in Nigeria, one of the things that happened, one of the places I love very much in Nigeria is a place called Boko in Benue State. They have the best mangoes. And everybody that know me know that I come to Nigeria, buy a ticket for $3,000 to go to Nigeria to eat mangoes. And my wife says, why can't you just use the $3,000 and buy mangoes here? I say, it's not the same. Doesn't taste the same. But the reason I'm saying that is when I go to Boko, I always feel bad because when it's mango season, there is mangoes everywhere. And then suddenly there is no mango. And you can't even find mango juice. You can't even find orange juice. So, but in the US, I can have orange juice throughout the whole year. I mean, even the orange is just produced maybe in Florida and California. But the issue is that some of these things hasn't been, the implementation science should go in agriculture to say, how do we keep this orange that is so abundant in Benue State all through the year for people who live in Abuja and Lagos? And that may be an industry that is sited in Benue. You don't want to take that industry and go put it in Anambra State where there is no orange at the commercial level, which is what happens in Nigeria because, the person that is agriculture minister is from Anambra State, which is my state. But instead of putting it in Benue State, where the oranges are there, and we can get it and supply everybody in the country orange. Okay, let me not go there. But what I'm trying to say is that implementation science can be used in any field. Give me any field, I can tell you why implementation science is very important. Because if we can implement what we know, we can solve 80% of the problems. Most of the problems we have, we already have solutions to them. The reason that we're not having them is implementation. People know that in most African countries, they have very good laws, they have very good principles, but the problem is implementation of those things. So can implementation science be used in law? Yes. Can it be used in oncology? Absolutely. But there's something in oncology that I'm also interested in for those people who are in oncology. It's actually the process of de-implementation. And that's something that we're going to talk about. We didn't talk about it here. We're talking about the building blocks of implementation science. But also there is another aspect that is very interesting, which is de-implementation, which is stopping those things that is not useful. So just like we remember when there were people used to kill twins because they think they were witches. And then you're able to de-implement that kind of intervention, killing the twins and they'll be able to change it. Those things, they didn't have a name then. They didn't have define it then. They didn't, do everything they needed to call it implementation. But that's what it was. We're able to find a way to do that. So what am I saying is that implementation science is an universal science that does not end only in medicine or in any aspect of medicine, but can apply to everything that we do in life. Thank you.
Thank you. So, sir, we have two questions on finance. Dr. Lawal says, finance is a big challenge to implementing HPV screening test in low resource settings. So will it be implementation science to consider theory of resource stratified implementation as a short-term solution?
Yes, implementation science to look at alternatives are always good, but in looking for that alternative, you always have to remember what economists have taught us when we're beginning our career, which is the alternative or the things forgone, the opportunity cost. So for example, one of the best ways to screen for cervical cancer is to prevent cervical cancer is to vaccinate people. So number one, that's it. So for the past 10 years, there have been a HPV vaccine available in the world. It's not in Nigeria, except for the rich and famous that can go get it anywhere else. But it's not part of the health system in Nigeria and in so many other African countries. But that's one of the most important ways that we have learned that we can prevent that. So then let's go about testing and screening people. One of the most important ways to do that is also HPV testing. At the beginning of research, the research we're doing actually is not doing HPV testing, it's doing the VIA testing. Because there was a reason for the VIA. The VIA was able to be scaled up and reaches every other place because of the cost associated with the HPV screening. But the cost for the HIV testing is coming down because new machines are coming out that can do something that wasn't done before, be able to give you result in 10 minutes. So you didn't have to take the test, send the woman home, bring them back the next day to give them the result. But you can 10 minutes, you can give them the result. So with those kind of advances in science, what used to be the best mechanism may not be the best mechanism. But does that mean that we need to stop doing VIA and now everybody has to do HPV? Well, HPV, that machine is not in my village, but my village can still do the HPV screening using VIA. So also, as we bring in new things, that's why implementation is important. It doesn't mean that we say, yes, this is the best thing to do, just like we know in Africa, we're talking about HPV vaccine. We're talking about 3 doses or 2 doses in the US. We're talking about even getting 1 dose into every girl will help in Africa. So does that mean you don't have to get 2 doses? No, but get 1 dose to most people that you can. That on a scale of population health, that will have more than getting a few people who got 3 doses. So I don't know if that answers your question.
Yeah. Okay, so Davidson is thanking you for a well-delivered lecture, and he's also reiterating that funding is a major challenge to carrying out implementation research in Nigeria. But he says, how can advocacy be intensified to get government and policymakers get involved in the provision of funding for implementation research in Nigeria?
And they're beginning to do so. I have to say that I'm impressed with what I see. I hope that things will, I remember when I was in medical school, there was nothing about research, research at all, but talk about anybody funding research. No, all we were doing is knowledge, attitude, and practice. We call it KAP. That is the research study of the poor man, because it didn't take a lot of money, but it's even taking more money now because you have to print the papers and the papers are expensive. But for example, countries like Nigeria, they now have the TED Fund, and TED Fund has funding and providing funding for people who do research. I have had people who win it. So I believe that people get it. And so I think there's becoming that interest that there have to be locally funded research projects, because some of those locally funded projects may fund what is more important to Nigeria that other people may not fund because it's Nigerians. Because when you look at studies, when you submit funding, there's one word you hear. Is this study generalizable? So if that becomes the very important thing, but you might see that some things that may solve problems that are unique to Nigeria will not be funded because it's not generalizable, but it may be very important for Nigeria. So there's a role for our government in Nigeria or in any other African countries to fund those studies that may not be generalizable to all the countries, but it's very good for their country and their own context and their own environment. So you cannot talk about local funding without it. It is. And advocacy is one way to show them why that this study may not be funded by NIH, but why you think it's important that your country, your setting, your state fund this study because of what you would do for your state, for your people, for that context where you are. So I do believe that local funding is going to be very crucial to solving a lot of the problem and to advancing implementation science, because some of the things, benefit of implementation science may be local context and may not be generalizable. Yes, the people who now do the science will now look at what you use and be able to name them, so that those things you gather people in the village And then, but it's something in the US, they gather people in the Congress. Then that those same thing is called focus group. So they can begin to form uniform names so that they can understand that that stuff you are doing in Nigeria by gathering people under the mango tree, that is called focus group. And it's the same thing they did by gathering the people in very big hotel in the US. So being able to have those common languages, that's why I like some of the things on implementation strategies, where they're beginning to define the implementation strategies, name them, define them, and specify them, so that when you use them in a place, you can, everybody has a language to understand that we're not doing video science in Africa, that we're actually doing science, because now we have named them and we have defined them and specified them. Thank you.
So we're at the top of the hour. It's 5 p.m. West African time, but we'll just take one question and one comment. So the question is that given the important role of evidence-based research in implementation science, how relevant do you think is the ability to conduct systematic reviews for someone who wants to be an implementation scientist or researcher?
To be honest with you, if I wanted to hire someone and they can do systematic review and has published one, they will go top on my list of hire. It is a skill set. Why is that important? Because for you to actually develop an intervention, for you to design a study to implement it, you need to know what the state of the science is. What do we know about this problem? What do we know about other solutions that have worked? What do we know that the ones that haven't worked? So if you look at all of this, what you are going to find out is that you're going to find out that this skill is important, that at least one person in the team has that skill, who can quickly be able to look at this literature in a systematic way and be able to come back with the team and say, this is what is out there. This is, I remember the first time we wrote a grant and we said, this is the first study. The reviewer sent us 5 studies that were done and said they did not do the basic. I mean, he gave us 0, almost the lowest score that was given. I never really got a 9 in NIH studies, but this one gave us 9, 9, 9, 9, because he was so upset. It happened that 3 of the studies that he sent to us was the work he has done. And we didn't do the literature review enough to see that he has worked on this area, and we say we are the first to do it. Really, who are we? So again, being able to review the literature is very important. And somebody in your team having the skill of systematic review is something. If you ask me a skill to get, that will be my number 1 for a scientist.
Okay, thank you, Prof. So the comment here is from Donatus, and he's saying, thank you so much. His suggestion is that in subsequent webinars, it would be great to elaborate on implementation science indicators in the context of resource-limited settings.
Okay.
Yes.
One of the things that we also gave you emails, and those emails are the emails that I put up here, just in case you missed it. But I do want you to take those emails to the end. To put it there, you can put it, Dr. Nyeka, on the Dropbox. What we want is so people to remember that. So send us an email at citia@unn.edu.ng with suggestions of things you would like to be included in the monthly webinar. I do want you to know that next month we'll be talking about research ethics. And in December, we are going back to our series we call Pathways in Medicine. That pathway in medicine is where we bring people who have picked non-traditional pathways in their career development. So it's our career development month that we usually talk about mentoring and talk about different pathways. So people who have finished medical school and went to public health and don't see patients, people who have finished and went to see patients, people who have finished and went to the drug industry, people who have finished and went to teach at the universities, people who have followed different pathways. We do that. We don't talk only about doctors, we talk about nurses and other healthcare workers. So we bring in speakers, and I think in December, we are bringing in somebody who finished medical school and went to do health informatics, and now that's what they do and has been the top of their game. So this email is important for you to send us topics that you want. One of the things we brag about is that we can bring any speaker to speak to our team and all of you. And the reason we say that, they know that we do good work and we know that we do it for free. And we want to make sure that it's available to as many people as possible. And when we ask, we have received people coming. So we did what we call NISA Research Week, which happens every quarter. And we bring in the best of the best from the world to come in and then talk. And what we do is that when we bring them, we bring in somebody from Africa. So example, we bring in Gregory Aarons, who developed EPIS. Then we bring in somebody from Africa who have used EPIS framework in Africa, and we match them together. So do make sure that the email that we have is the correct email, and then so that you'll be in touch. At least you can receive that email. I know that you can't join all of them, but you might see the ones that interest you and you can join them. So please make sure that the emails that you use in registering, that is more important. We're not going to go to the chat to copy your emails. It doesn't work. Nobody has that time. Like, you know, we're all doing this for free. So the best way to give us the email is when you register, give us the correct email and we will get back to you. You'll be on our email, on our listserv, and you will get all the monthly webinars, all the quarterly research work, and you can attend the ones you're able to attend. Thank you all for taking time to listen to me, and I appreciate you all. Thank you.
Prof, and thank you everyone for joining. Just an extra 6 minutes beyond the hour. We'll see you next month. That will be the 2nd of October with another webinar on research ethics. So until then, take care, stay well, and be blessed. Bye-bye.
Bye.